Howdy, folks. Welcome to Reading Cowboys Deep Dives Heart Health Series. It's a good day to be on the trail, and today, well, we're saddling up for a crucial conversation that impacts more women than you might imagine. Get ready for some eye-openers. You ever heard someone say, oh, it's just stress when a woman talks about her chest pain? Or maybe seen a movie where a heart attack looks like someone clutching the chest dramatically and falling to the ground? Well, hold on to your hats, because what we're about to unpack might just surprise you. We're going to bust some myths that have been hanging around longer than a dusty old saloon, and maybe even share a chuckle or two along the way. Because even with a serious topic like heart health, learning can and should be a joyful ride. The truth is, heart disease is the #1 killer of women, both here in the U.S. and over in the U.K. It actually outdoes all forms of cancer combined. That's a stark reality, yeah. Yet for far too long, it's been seen as man's disease, a perception that's led to countless misdiagnoses and dangerous delays for women. It's like we've been looking for trouble out in the North Pasture when it's been quietly grazing right in the South one all along. Today, we're promising you simple explanations, practical tips you can use right away, and some truly eye-opening insights into why women's heart health is often, as some folks in the know call it, misdiagnosed. We're going to dive deep into the facts, shine a light on the shadows, and empower you to be a champion for your own heart and the hearts of the women you love. So let's stop dilly-dallying and get this deep dive started. The hidden epidemic. Why women's hearts are different and overlooked. All right, let's unpack this. The numbers tell a stark story right from the get-go, don't they? It's clearly not just a man's disease at all. In fact, when you look at the cold, hard facts, it becomes obvious that this old notion is not only outdated, but, well, actively harmful. It's like finding out your trusty old map is pointing you in the wrong direction entirely.
What's truly fascinating here, and frankly deeply troubling, is how profoundly ingrained this misconception is. It's not just in public perception, you see, but historically, even within medical understanding itself. This isn't just a minor oversight, it's a narrative that urgently needs a complete rewrite, really. Cardiovascular disease, or CVD, that's the umbrella term for all conditions affecting the heart and blood vessels, it stands as the leading cause of mortality for women in the United States. Tragically, it results in more deaths than all forms of cancer combined. We're talking about a major public health crisis that has been simmering for decades, largely hidden in plain sight, out of the spotlight it desperately needs.
Wow, more than all cancers combined. That really puts it into perspective.
It does. And over the past 2 decades, thanks to what we call transdisciplinary research, that's basically when scientists from different fields like cardiology, genetics, endocrinology all work together, we've seen significant advancements. These collaborations have truly deepened our understanding of how CVD affects women. And here's a key insight. We now know that the conventional risk factors we often talk about, things like high blood pressure or hypertension, tobacco use, and diabetes, they actually impact women differently than they do men. It's not a one-size-fits-all equation, and treating it as such has caused real problems.
Differently, you say. That's a crucial distinction.
Right.
Can you give us an example? How might, say, high blood pressure or diabetes play out uniquely for a woman's heart compared to a man's?
Absolutely. It's a vital point that often gets overlooked. Let's take hypertension, high blood pressure. In women, it often shows up differently. Isolated systolic hypertension is more common. That's when just the top number in your blood pressure reading is high, while the bottom number is normal. This type can carry higher risks for women than for men, and sometimes even lower blood pressure readings can signal higher risks in women compared to what we see in men.
So the standard cutoffs might not even apply the same way.
Exactly. Or consider diabetes. It tragically erases much of the natural heart protection women have from estrogen. It increases their heart disease risk even more dramatically than it does for men. It's like their protective shield gets an extra dent, a bigger one,
Right.
And tobacco use. Sadly, smoking often carries even greater and sometimes more immediate heart-damaging consequences for women, especially younger women. It leads to higher rates of heart attack and stroke compared to male smokers. These aren't just minor variations, they're fundamental differences in how these risks play out.
Okay, so the traditional risks hit differently. What about factors unique to women?
Right. Beyond these traditional factors, we've identified unique female-specific and female-predominant risk enhancers. These are conditions or situations almost exclusively found in women, or much more common in them, like certain pregnancy complications or autoimmune diseases, which are more prevalent in women. These distinct elements should absolutely be factored into risk assessments for women, helping us move away from a generalized approach and towards truly personalized care.
That makes sense. Tailoring the assessment.
But here's the kicker, and it's quite concerning. Despite these crucial scientific advances, the prevalence of traditional atherosclerotic cardiovascular disease, or ASCVD, that's the common type where fatty plaques build up and harden your arteries, kind of like rust in a pipe. And its traditional risk factors like diabetes, obesity, and hypertension has actually increased among women younger than 55 over the past decade.
Increased. Even with more knowledge. That's counterintuitive.
It is deeply concerning, especially when coupled with the fact that the rate of decrease in CVD-related deaths has not only plateaued, but has in fact increased in younger women. To put it in perspective, about 1/3 of all CVD events now occur in women under the age of 65.
Wow. That's a gut punch. 1/3 of all heart events in women under 65. It's like we're caught in a slow-motion ambush. You used a great analogy earlier about a slow-burning fire. Could you remind us of that?
Of course. Imagine a bustling town. Everyone thinks the only big trouble is a wildfire way out west, and all the resources are focused there. But there's a slow-burning fire right in the heart of the community, quietly spreading through the homes and businesses, and nobody's looking for it there because they're fixated on the known threat. That's a bit like how women's heart health has been treated. We've been looking for the man's disease presentation, and in doing so, we've missed the unique, dangerous signs in women.
And it's not just that women aren't aware. It sounds like the folks in the medical community might be caught off guard too. It's like we've got a whole herd of doctors still looking at the old maps while the landscape has changed significantly right under their noses.
Precisely. It's a huge part of the problem. Despite almost 2 decades of national efforts to increase awareness, it has actually decreased significantly among women themselves. We've gone from 65% awareness in 2009 down to a disheartening 44% in 2019 across all racial and ethnic groups. And this drop is most notable in the crucial 25 to 64-year-old age range.
Less than half. That's genuinely shocking. Women are less aware now.
It's a worrying trend. Think about that. Women are less aware of their number one killer now than they were a decade ago. And the medical community isn't entirely prepared either. A striking statistic shows that only 22% of primary care physicians and a mere 42% of cardiologists felt adequately prepared to assess CVD risk in women.
Less than half of the heart specialists feel ready. That's a huge gap.
It is a concerning knowledge gap. And this gap, both for patients and providers, must be feeding into bigger issues down the line, right?
Absolutely. It sounds like a cascading problem.
It is. This profound knowledge gap directly contributes to the noted underutilization of preventative therapies in women when compared to men. Women are simply not getting the preventative care that could save their lives. It's not just an isolated incident. It's a systemic issue where knowledge gaps exist at multiple levels, from public awareness campaigns failing to resonate to the very training and ongoing education of healthcare providers being insufficient. It's a challenge that demands a comprehensive approach, from a woman's initial perception of her symptoms to a clinician's diagnostic accuracy.
So what does this all mean for women once they've actually developed heart disease? It sounds like they've already had to jump through enough hoops just to get to that point, and it doesn't get any easier, does it? It's like they've already ridden a tough mile and the trail ahead is still full of obstacles.
You're absolutely right. When we connect this to the bigger picture, once women have CVD, there are continued sex disparities in diagnosis, treatment, and ongoing management, which sadly and unfairly lead to worse outcomes for them. These disparities are not minor inconveniences. They are life-altering and often life-ending.
Worse outcomes? Like what specifically?
Well, this includes significant delays in receiving care, the underutilization of guideline-directed medical therapies, these are the proven treatments we know work face, and a lack of access to crucial cardiac rehabilitation programs. Compared to men, women often receive less aggressive treatment across various CVD diagnoses, including acute coronary syndromes, heart failure, and valvular disease.
Less aggressive treatment, even for the same conditions.
Yes. The unfortunate result, we persistently see higher mortality rates and increased rehospitalizations in women when compared with men. And to further complicate matters, women are also consistently underrepresented in clinical cardiovascular trials.
So the research itself is still lagging behind for women.
Exactly. This makes it incredibly difficult to fully understand and develop treatments that account for sex differences in new medical therapies, devices, or other interventions. It creates a vicious cycle of insufficient knowledge and unequal care. It's a critical area that urgently needs to be addressed to ensure equitable and effective heart care for all. 2, decoding the symptoms. what women really experience.
Okay, here's where it gets really interesting, partner. We've all seen those movie scenes of a heart attack, the sudden crushing chest pain, the arm clutched dramatically. It's become almost a cliche, right? We probably all mimicked it at some point. But women's heart attacks often don't look like that, do they? They can be as subtle as a tumbleweed rolling by, or as misleading as a mirage on the horizon.
That's absolutely right, and it's a dangerous misconception that's costing lives every single day. The classic heart attack symptoms, the ones Hollywood loves to portray, they're predominantly based on male presentations, but women frequently experience less obvious, more confusing warning signs. Here's a mind-boggling fact. In one crucial study, a staggering 62% of women treated for heart attacks did not have chest pain.
62%.
62% compared to 36% of men. Think about that for a moment. Nearly 2/3 of women having a heart attack weren't experiencing the symptom most people, and tragically, even some medical professionals expect. This is a critical distinction and a major, major reason for misdiagnosis.
Wow, 62% without chest pain.
Yeah.
That completely blows apart the Hollywood image we all have. It truly is like trying to spot a tumbleweed in a dust storm when you're looking for a charging bull. How did we get it so wrong for so long that this classic picture became the default, even for medical training?
It's largely due to historical research patterns, which, as we mentioned, predominantly studied men. So the norm became male symptoms. But for women, while chest pain or discomfort is still the most common symptom for both sexes, women often describe it differently. It might not be the crushing elephant on the chest pain you see on screen. Instead, it could feel like an uncomfortable pressure, a squeezing sensation, or maybe a general feeling of fullness in the center of the chest.
Pressure or squeezing, not necessarily sharp pain.
Exactly. And crucially, this discomfort may last more than a few minutes, or perhaps even more confusingly, it might go away and then come back. That makes it seem less severe and therefore easier to ignore or dismiss,
Yeah, intermittent symptoms are tough. So what else should we be looking for besides chest discomfort?
Right. Beyond the chest, other signs are often present and demand our attention. These include pain or discomfort in other areas. This can be felt in one or both arms, the back, neck, jaw, or stomach. Women might describe upper back pressure that feels like squeezing or even a rope being tied around them.
A rope around the back. That's very specific and different.
It is very different from the sharp, radiating pain often associated with men. Then there's shortness of breath. This can occur quite suddenly and significantly, with or without any accompanying chest discomfort. It might feel like you've run a marathon when you've just walked to the mailbox, or like you just can't catch your breath.
And other signs. You mentioned subtle ones, too.
Yes, other subtle signs. These can be even more misleading. Breaking out in a cold sweat, feelings of nausea or even vomiting, lightheadedness or dizziness, an unusual and overwhelming tiredness and weakness that you just can't shake, and even anxiety or an upset stomach.
Right. I can certainly see how some of those might be easily confused with other everyday things. Oh, I'm just tired after a long day, or must be a touch of indigestion after that chilly dinner. It makes it tricky for a woman to know when to speak up, doesn't it? It's like her body is sending out smoke signals, but everyone's looking for a fire alarm.
Precisely. Because these symptoms don't fit the standard male-centric heart attack narrative that most people, including many healthcare providers, have ingrained in their minds. They are frequently mistaken for much less serious conditions. We hear heartbreaking stories of symptoms being misattributed to things like panic attacks, severe acid reflux, the flu, or even just normal aging.
That's terrible, just waved away.
And this misinterpretation leads to a critical and alarming finding. Women under the age of 55 are 7 times more likely than men to be sent home from the emergency room without proper cardiac testing.
7 times.
7 times. That number alone makes my blood run cold.
7 times more likely. That's not just a statistic, it's a terrifying reality for many women. But why? Is it a lack of training or something more deeply ingrained in how we view women's health complaints in the ER? Are doctors actively missing these signs, or are they just not equipped to recognize them?
It's a complex mix. This alarming trend is why the term misdiagnosed has emerged. It highlights the dangerous delays in care and the increased risks of long-term heart damage or even death that women face. It underscores a systemic failure to recognize and appropriately respond to women's unique cardiac presentations. And to answer your excellent question, it's definitely multifaceted. It's not just one factor, but a complex interplay of historical, societal, and systemic issues that create this bias. It's almost like a tangled rope that takes a lot of effort to untwine.
Okay, so break down those factors for us. What's tangling this rope?
Firstly, there's medical bias and outdated research. As we discussed, historically, heart disease research predominantly focused on men. For decades, women were significantly underrepresented in clinical trials. This created a profound gap in our knowledge about female-specific symptoms and the unique pathophysiology that's how the disease develops and progresses of heart disease in women. Consequently, many healthcare providers, even today, still rely on these male-centric diagnostic models. They're taught a certain classic presentation.
And when a woman doesn't fit that exact picture?
It's easily dismissed because it doesn't fit the textbook they learned from, perhaps years ago.
Okay, outdated research is one piece. What else?
Secondly, gender stereotypes in medicine play a significant, often unconscious role. Societal biases can unfortunately influence how doctors interpret symptoms. Women are sometimes more likely to be perceived as anxious or emotional, which can lead some providers to attribute their symptoms to psychological rather than physical causes.
The old, it's just anxiety brush off.
Exactly. We've heard heartbreaking stories from women who were told it's all in your head, you're just stressed, or it's just anxiety, when they were in fact in the midst of a serious cardiac event. Men, on the other hand, presenting with the very same symptoms, are more often taken seriously and given immediate cardiac testing. That highlights a clear and dangerous disparity in approach.
It's unsettling to think that doctors, who are trained to heal, might carry unconscious biases. Is this truly a widespread issue? Or are we perhaps overstating the impact compared to, say, just the difficulty of recognizing these different symptoms? What's the strongest evidence we have that gender stereotypes are actively leading to misdiagnosis in real time?
That's a fair question, and it's something the medical community is grappling with. While the unique presentation is certainly a factor, studies have actually shown that when men and women present with identical atypical symptoms, women are still less likely to be referred for further cardiac evaluation. This points directly to an implicit bias at play, unfortunately.
So even with the same symptoms, women get treated differently.
The data suggests so. We see this borne out in patient anecdotes, but also in data on ER visits, where women are sent home at higher rates. It's not about malice, usually, but ingrained assumptions that need serious challenging.
Okay, bias and stereotypes. Is there a third factor?
Yes, and finally, cultural norms themselves contribute to the problem. Many women tend to downplay their own symptoms. They might assume they're not serious, or they might fear they'll be seen as dramatic or complaining too much.
Yeah, women are often socialized not to make a fuss.
That's right. This is often reinforced by cultural expectations that place women in caregiving roles, leading them to prioritize the health and well-being of their families over their own. This self-neglect, combined with the other biases, creates a perfect storm for delayed and missed diagnoses, making a tricky situation even more perilous. 3. The hormonal frontier. Menopause and heart health.
Okay, shifting gears a bit here. We hear a lot about how women's bodies change over time, especially with menopause. Does that pivotal life stage play a big part in heart health too, or is it just another one of those old wives' tales, like predicting rain from a cow's tail?
Oh, indeed it does. And it's a critical frontier in understanding women's cardiovascular risk. This isn't just a minor connection, it's a fundamental shift in physiology that profoundly impacts a woman's heart health. Here's the core insight. Women typically develop heart diseases a few years later than men, on average.
Right, we often hear that.
And this delay is largely due to the protective effect of endogenous estrogen. That's the estrogen your body naturally produces during their reproductive years. Estrogen, in a way, acts like a natural shield, guarding the cardiovascular system. However, once women enter menopause, this natural shield diminishes, and with that, the risk of CVD significantly increases. It's a biological transition with serious cardiovascular implications.
So estrogen is like a natural heart protector. How does it actually work?
Well, at its core, estrogens, especially the type called estradiol or E2, act like a natural armor for the heart in several ways. They positively influence plasma lipid profiles, helping to keep your cholesterol levels healthy, raising the good kind, HDL, and lowering the bad kind, LDL. They also possess antiplatelet properties, meaning they help prevent blood clots, and antioxidant properties, which fight off cell damage from things like oxidative stress. It's essentially cellular wear and tear.
Wow, it does a lot.
It really does. What's more, they actually stimulate angiogenesis, the growth of new blood vessels, and vasodilation, which means widening existing ones, ensuring good blood flow. It's a remarkable built-in protective system that does a lot to keep the heart running smoothly for many years.
So it's like a natural, built-in defense system that eventually wears down after years of loyal service, leaving the heart more exposed. That's a good way to picture it, like a loyal ranch hand who's been protecting the homestead for decades and then retires, leaving the gates a little less guarded.
That's a very good analogy. Perfectly captures it. With the decline in estrogen during the menopause transition, several unfavorable changes occur that significantly elevate CVD risk. For example, women commonly experience an increase in blood pressure, which is a major risk factor. We also see increases in body mass index, BMI, and overall obesity. With central obesity, that's fat accumulation, particularly around the abdomen, becoming much more prevalent. In fact, central obesity can be up to 5 times higher in postmenopausal women compared to their premenopausal counterparts.
5 times higher, just from menopause.
It's a significant shift.
Yeah.
There are also changes in body fat distribution that are less favorable for heart health. And furthermore, there's a higher incidence of dyslipidemia, meaning unhealthy cholesterol levels. Specifically, there's often an increase in LDL-C, the bad cholesterol, and triglycerides, while HDL-C, the good cholesterol, tends to decrease.
So cholesterol gets worse, too.
Often, yes. And the occurrence of metabolic syndrome, that's that dangerous cluster of issues like high blood pressure, high blood sugar, excess waist fat, and abnormal cholesterol all at once, is 2 to 3 times more likely in postmenopausal women. And we know that menopause before age 40, which is considered premature, or between 40 and 44, classified as early, is linked to a higher risk of hypertension and type 2 diabetes.
Why is that?
It's due to this more prolonged estrogen deficiency. There's even increased sensitivity to sodium, which can lead to fluid retention and put additional strain on the cardiovascular system.
It affects so many things. You had another analogy for this about a river.
Yes. Think of it like a river flowing smoothly and protecting the banks for years, keeping the land fertile and stable. But when the water level drops significantly, those banks become more vulnerable to erosion and unseen pressures. The whole ecosystem shifts. The heart, in this case, is that vulnerable land, facing new challenges without its previous natural defenses.
Okay, that paints a clear picture. We've talked about a lot of factors that can go wrong after menopause. What about hormone therapy, or HT? Does that help keep the shield up and reinforce those riverbanks, or is it a whole new set of considerations, like trying a new fence that might have its own quirks and challenges?
Right. This is where it gets nuanced, and the data has certainly evolved over time. The role of hormone therapy in CVD risk has been quite controversial in the past. Remember the big Women's Health Initiative study? It caused a lot of confusion and fear for both patients and providers.
I do remember that. A lot of women stopped HT then.
They did. However, more recent data, looking closer at the types, doses, and timing, offers a clearer picture now. It suggests that oral or transdermal HT, especially when initiated at low doses and early in the menopause transition, generally does not increase the risk of heart disease. In fact, some observational studies have even shown beneficial cardioprotective effects. The key here is when and how it's initiated.
So the timing and the type really matter. What's
Yeah.
considered safer now?
The key nuance here is the type and timing. Low-dose transdermal estrogen, that's estrogen delivered through the skin, like a patch specifically less than 50 micrograms per day, when used in combination with micronized progesterone, which is chemically identical to the progesterone the body makes, appears to be an innocuous choice for CVD risk.
Innocuous choice. So pretty safe from a heart perspective.
Generally, yes. This particular approach is not associated with an increased risk of venous thromboembolism, or VTE, those serious blood clots that were a significant concern with older, higher-dose oral HT regimens. It also typically doesn't raise triglyceride levels, unlike some oral estrogen formulations, and can even delay the progression of atherosclerosis, the hardening of the arteries. It's a much safer profile.
Okay, so transdermal, low-dose, early start seems key. What if someone starts later?
Good question. For application, if HT is initiated more than 10 years after menopause or after age 60, it's generally recommended at the lowest possible dose for the shortest duration necessary to manage symptoms. And transdermal administration is still highly recommended due to its better safety profile concerning coagulation and lipids compared to oral forms. Ultimately, individualized pharmacotherapy is crucial. That means tailoring the treatment specifically to each person, including a thorough baseline CVD risk assessment before starting anything. It's not a blanket recommendation, but a personalized decision made between a woman and her doctor.
Right, always personalized. So you mentioned earlier menopause carries higher risks. The actual age a woman goes through it matters down the line for her heart. It's not just about hot flashes and mood swings ending sooner, but something with a much longer reach.
Absolutely. The age at natural menopause, or ANM, has a significant and long-lasting impact on a woman's health, particularly her cardiovascular well-being. Women experiencing premature menopause, which is before 40, or early menopause, between 40 and 44, have a significantly increased risk of experiencing a non-fatal cardiovascular event before the age of 60.
A significantly increased risk, just based on the timing of menopause.
Yes. This factor should be considered a strong warning sign during medical consultations, prompting closer monitoring and more proactive preventive strategies. It's like an early warning signal that the trail ahead might be rougher for her heart.
Are genetics involved in when menopause happens?
Definitely. We also know that genetic factors play a major role in determining the timing of menopause. Interestingly, some genetic variants linked to an earlier ANM are also associated with increased coronary artery disease. And other cardiovascular risk factors, such as higher BMI and hip circumference. This highlights a complex interplay between our genes and our environment and how it manifests in long-term health.
Fascinating. Is there anything on the horizon to predict this earlier?
There is. Looking to the future, new research may focus on emerging biomarkers. These are biological indicators, such as anti-Mullerian hormone, or AMH. This hormone level can help estimate the timing of a woman's final menstrual period, FMP, with more accuracy than just age alone.
So you could potentially know years in advance.
Potentially, yes. This could offer earlier and more precise insights into her individual CVD risk trajectory. This kind of predictive tool could revolutionize how we approach early intervention and personalized care, giving women a better chance to stay ahead of heart disease by preparing for potential challenges long before they arise. 4. The unseen burden: psychosocial stress and women's hearts.
Now, this next point might surprise some folks, but our minds and emotions can hit our hearts hard, can't they? Especially for women. It's like carrying a heavy saddlebag filled with worries every day, and that weight eventually takes its toll on the trail, wearing down even the strongest rider.
That's profoundly true, and it's a critical area that's often underestimated and underaddressed in cardiovascular health. Psychosocial stress, that's the kind of stress arising from our social and psychological environment. It significantly impacts CVD through multiple, often complex biological and behavioral pathways. What's particularly striking is that certain stressors are especially common among women, and their consequences can be even more pronounced for cardiovascular risk in women than in men. This isn't just about feeling stressed out, it's about a tangible, modifiable risk factor that has direct, measurable effects on the heart. It's like a silent leak in your defenses.
So we've seen how stress can physically impact the heart through things like high blood pressure. But what kind of stress are we talking about here specifically impacting women more? It's not just the everyday kind, like worrying about bills or a busy schedule, is it? It sounds like women often carry a lifetime of unseen burdens. Tell us about these deeper storms.
You've absolutely nailed it. It's a broad spectrum ranging from acute short-term stress, like a sudden scare or a big argument, to chronic, persistent pressures that can last for months or even years, slowly chipping away at one's resilience. And women, unfortunately, face a distinctive burden of psychosocial adversities throughout their lives, often disproportionately compared to men. It's truly a silent crisis for many.
Okay, break down some of these specific stressors for us.
Let's do that. First, socioeconomic disadvantage. Financial adversity, limited access to education, restricted employment opportunities. These are more strongly associated with coronary heart disease, CHD, and overall CVD in women. First, socioeconomic disadvantage. Women are often overrepresented among low-income earners, and this disadvantage creates a cycle of stress that impacts health, often forcing hard choices between immediate needs and long-term well-being.
So poverty and lack of opportunity literally hurt the heart.
The link is strong. Then there's childhood adversity. Experiences like severe physical or sexual abuse, significant family conflict, or parental absence are tragically more common in girls. Then there's childhood adversity. These experiences are robust predictors of a 50% higher risk of early-onset CVD events in women later in life.
50% higher risk from childhood trauma. That's staggering. How does that connection work?
It's often mediated by unhealthy behaviors adopted as coping mechanisms, like smoking or overeating, but also through enduring biological changes caused by chronic early stress. It essentially wires the body to be more reactive to stress throughout life.
Wow. Okay, what else?
Intimate partner violence, ITV. This deeply disturbing issue affects about 1 in 4 women and is directly linked to a 29% to 51% increased risk of CHD, stroke, and diabetes later on. And interestingly, emotional abuse specifically can show even stronger associations with the development of hypertension than physical violence. It's a profound hidden stressor.
Emotional abuse hitting blood pressure hard. That makes sense, a constant tension.
It does. Also, marital stress. The link between the quality of a marital relationship and cardiovascular risk appears stronger in women. Among female patients already diagnosed with CHD, significant marital stress was associated with a nearly 3-fold increased risk of recurrent coronary events.
So a difficult home life can literally break a woman's heart again.
The data suggests a strong connection. Then there's caregiving stress. Women represent over 80% of unpaid caregivers worldwide. This immense burden, whether caring for children, elderly parents, or sick spouses, is linked to increased stress and adverse health outcomes. Then there's caregiving stress. Female caregivers frequently report worse sleep problems, which in itself is a significant cardiovascular risk factor. It's a selfless act that often comes with a steep personal health cost.
The sandwich generation stress is real.
Very real. And finally, race and ethnicity. Black women face what researchers term gendered racism, a powerful and unique hybrid of discrimination based on both race and gender, race and ethnicity. This double burden is directly linked to higher rates of CVD, hypertension, and obesity. Hispanic women, especially Puerto Rican women, often report more psychosocial difficulties and acculturation stress, adapting to new environments. These are distinct, layered stressors.
That's a lot of weight to carry. Like a full pack horse on a long, hard journey. And it sounds like these things don't just affect our minds, they show up physically in our bodies too, don't they? Our hearts literally take a beating from these unseen struggles. How does stress actually translate into physical heart problems biologically?
Exactly. The way our bodies respond to stress, especially unhealthy, prolonged stress, actually works through these really complex biological and behavioral pathways. And here's the key thing. They're often sex-specific. They play out differently in women compared to men. It's not just stress is bad, it's stress is bad in specific ways for women's hearts.
Okay, tell us about those biological pathways.
All right, on the biological pathway side, first, neuroendocrine and autonomic dysregulation. Chronic stress can throw your body's central stress control panel, the hypothalamic pituitary adrenal or HPA axis, and your autonomic nervous system, your fight or flight and rest and digest systems, out of whack. Here's a fascinating insight. While women, especially before menopause, often have a higher rest and digest or parasympathetic tone when calm, they can be more susceptible to the damaging effects of prolonged fight or flight or sympathetic hyperactivity when stressed.
So they might rest better but react worse to chronic stress.
In some ways, yes, their internal alarm system might get stuck on more easily, constantly taxing the heart. This dysregulation can also affect ovarian function through the hypothalamic pituitary gonadal axis, creating a feedback loop of stress and hormonal imbalance.
It's a vicious cycle. What else biologically?
Second, immune function and inflammation. Acute mental stress triggers a more pronounced inflammatory cytokine surge in women than in men. These are like alarm bells signaling inflammation throughout the body. Women often show higher levels of interleukin-6, a key inflammatory marker. Furthermore, women can show decreased glucocorticoid sensitivity after stress, meaning their bodies are less effective at turning off the inflammatory response. It leads to more protracted or longer-lasting inflammation.
So women's bodies stay on fire longer after stress.
That's a good way to put it. And this increased prolonged inflammatory response is associated with an elevated risk of adverse cardiovascular outcomes, specifically among women with existing coronary heart disease. That link isn't as strong in men.
Okay, inflammation is key. Anything else?
Third, vascular function. And when it comes to blood vessels, women with heart disease often experience more severe vasoconstriction, especially in the tiny peripheral blood vessels. That's when they tighten up, almost like squeezing a hose. This happens more intensely in women, sometimes even at rest or particularly under mental stress, impairing blood flow to the heart muscle itself. This microvascular dysfunction problems with these very small vessels is a signature feature of conditions we'll discuss like MSEMI and INOCA.
Problems in the tiny vessels, not just the big ones. Got it. Now, what about behaviors? How does stress affect women's actions related to heart health?
Right. Then there are the behavioral pathways, where psychosocial stress significantly impacts key cardiovascular health behaviors, often more so in women. Smoking. Women are more likely than men to start smoking or increase smoking as a coping strategy for stress. They also tend to find it harder to quit and are more prone to relapse when stressed. This is particularly concerning because smoking is already more hazardous for women's hearts, especially at younger ages.
Using smoking to cope, but it makes the heart problem worse.
Exactly. Excess adiposity and dietary behavior. Stress, particularly daily stressors and chronic stress, can lead to emotional eating and binge eating. These behaviors are more prevalent in women and directly contribute to excess adiposity or unhealthy body fat, especially harmful fat around the middle. Physical inactivity. Sedentary behavior disproportionately affects women compared to men. And stress is inversely related to physical activity, meaning the more stressed women feel, the less likely they are to engage in beneficial exercise. It's a tough cycle to break.
Stress makes you want to eat comfort food and sit on the couch, basically.
It often does. And finally, sleep disturbances. Women are at a higher risk for poor sleep quality and insomnia than men. This risk is amplified during critical life stages like pregnancy, the postpartum period, or the menopause transition. And it's further compounded by caregiving responsibilities. We all know how vital good sleep is for heart health.
So these stresses, this unseen burden, can actually manifest as specific heart conditions that are more common in women, not just general heart problems. It's like stress carves out its own unique path to the heart, isn't it? Leading to very particular ailments.
Yes, absolutely. Several distinct cardiovascular conditions are intricately linked to stress and, tellingly, disproportionately occur in women. It's a clear demonstration of how profound the mind-body connection truly is, especially under chronic pressure. These are not general aches and pains. These are very real, very dangerous cardiac events triggered or exacerbated by stress.
Okay, what are these specific conditions?
First, we have mental stress-induced myocardial ischemia, MSIMI. Myocardial ischemia is a reduction of blood flow to the heart muscle. When it's triggered by acute mental stress, it's actually twice as common in women, particularly younger and middle-aged women, compared to men.
Twice as common. And is it obvious when it happens?
Yeah.
That's the scary part. MSIMI is often silent. Women might not experience the typical chest pain, yet it's associated with a twofold increased risk of adverse cardiovascular events down the road, like heart attack or death. And in women, that microvascular reactivity we talked about, how their tiny blood vessels spasm in response to stress, plays a more pronounced role in causing MSIMI.
Silent ischemia triggered by stress.
Terrifying. What's next?
Then there's stress-induced cardiomyopathy, commonly known as Takotsubo syndrome, or more evocatively, broken heart syndrome.
Broken heart syndrome, I've heard of that. Is it real?
It is very real. It's an acute, usually reversible dysfunction of the left ventricle of the heart that commonly follows an episode of intense emotional or physical stress. Think severe grief, sudden shock, extreme anger. It can literally cause a temporary but serious heart problem that mimics a major heart attack. It predominantly occurs in postmenopausal women.
Why postmenopausal women mostly? It's thought to be linked to a massive surge of stress hormones, what's called a catecholamine storm, combined with the lower estrogen levels after menopause. It's a very real physical manifestation of emotional trauma.
Wow. Okay, one more.
Yes. And finally, spontaneous coronary artery dissection, SCAD. This is a significant cause of heart attack and even sudden death among younger women, mostly around the time of menopause, perimenopausal. They represent a staggering 90% of EST cases, and often these women have few traditional risk factors like high cholesterol or blood pressure.
A tear in the artery. What triggers that?
SCAD is commonly triggered by intense emotional stress or sometimes extreme physical exertion. And notably, it is the most common cause of myocardial infarction heart attack during pregnancy and the postpartum period. These are not minor connections. They are direct physiological pathways from stress to severe life-threatening heart conditions, and they are overwhelmingly concentrated in women.
That's incredibly eye-opening. So what about those critical junctures in a woman's life, like when she becomes a mother or reaches menopause? Do those make things even tougher on the heart, like hitting a rough patch on the trail where every step takes more effort? It seems these aren't just personal milestones, but health flashpoints.
They certainly do. Reproductive milestones, menarche, the first menstrual period, pregnancy, and menopause are crucial considerations. These periods can exacerbate stress in vulnerable women and significantly influence their future CVD risk. They act as sensitive windows for cardiovascular health, almost like checkpoints on the trail where the stakes get higher.
Okay, tell us about menarche first. How does the first period link to heart health later?
For menarche, research shows that both early onset, meaning before 12 years old, and late onset, after 17 years old, are associated with increased CVD risk later in life. This is partly explained by factors like excess adiposity, body fat, and exposure to early life stressors that can influence pubertal timing, basically setting the stage for future heart issues.
Interesting. Now, pregnancy, that seems like a huge stressor, physically and emotionally.
Pregnancy is indeed an incredibly significant period. Maternal psychosocial stress and pregnancy-specific stress can predispose women to poor cardiovascular health during the pregnancy itself. This stress is linked to complications like preterm labor, low birth weight babies, and pregnancy-induced hypertension or preeclampsia.
And those complications have long-term effects.
Yes. These complications, in turn, are robust predictors of increased maternal CVD risk in later life, sometimes decades later. They cast a long-term shadow over her heart health. It's a critical reminder that a healthy pregnancy isn't just about the baby, it's also about a healthy future for the mother's heart.
Right. And finally, menopause again.
And as we've already touched upon, menopause is a profound transition. The menopause transition itself, with its complex biological, hormonal, social, and psychological changes, makes women highly vulnerable to psychological distress. We also see that earlier onset of natural menopause is strongly linked with an increased risk of CVD. These aren't just life events, they are critical health junctures that demand specific attention and care, as they truly reshape a woman's cardiovascular landscape, often increasing vulnerability. Tackling the trail. Barriers to diagnosis and pathways to solutions.
Well, this deep dive has certainly laid bare a lot of challenges for women's heart health partner. It sounds like there are hurdles at every turn for patients, doctors, and the whole darn system. It's like trying to cross a river with no bridge in sight. So after all that, what can we actually do about it? How do we start building that bridge to better health for women?
That's the million-dollar question, isn't it? And it's where we can start to build a better future. The challenges are real and complex, existing at the patient, provider, and health system levels. But crucially, so do the opportunities for impactful solutions. This demands a comprehensive blueprint for change, incorporating multidisciplinary, multi-level collaborations that tackle the problem from every angle. It's not about finding one simple fix, but many interconnected solutions working together, like a well-coordinated cattle drive getting the herd where it needs to go.
Okay, let's start with the patient herself. Let's talk about what stands in the way for you, our listener, and other women seeking care. What's the biggest barrier you've identified on the patient's own journey when she's trying to get himself to the doctor? It often seems like the first step is the hardest.
What's truly fascinating and often heartbreaking, here is the array of patient-level barriers. Many women, unfortunately, distrust or even avoid medical care, maybe because of previous dismissive experiences or just a general lack of confidence in the system. They may be completely unaware of critical family history related to heart disease, or they might not fully grasp the importance of reporting all their symptoms, even the subtle ones that don't fit the classic heart attack picture we discussed.
They might think that fatigue or nausea isn't important enough to mention for heart health.
Exactly. Beyond these knowledge and trust gaps, practical hurdles like financial barriers, lack of insurance, transportation issues, language differences, and cultural norms can significantly delay or completely prevent them from seeking timely care. This lack of empowerment or understanding can be a significant hurdle, making the first step towards diagnosis the hardest, almost like being lost without a compass in unfamiliar territory.
Okay, so for you out there listening right now, here's some straight talk from the ranch. You got to be your own champion for your heart. No one else is going to ride harder for your health than you. We've heard some truly alarming statistics today, but here are some practical daily tips, simple things you can start doing right now to take charge and ensure you get the care you deserve. Ready? First, know your symptoms, not just the classics. Understand that your heart attack symptoms might be subtle or different. Pay close attention to unusual fatigue, shortness of breath, nausea, or any pain or discomfort in your jaw, back, arms, or stomach. Don't dismiss these. Your body knows when something's truly off. Second, trust your gut and speak up. If something feels wrong, especially if it's new, persistent, or worrisome, don't downplay it. Trust your instincts. Clearly communicate all your symptoms to your doctor, even if they seem unrelated. And don't be afraid to ask directly, could this possibly be heart-related? That's a powerful question.
That direct question is really important.
It is. Third, insist on being heard and document everything. If you feel you're not being taken seriously or your symptoms are being dismissed as anxiety, request specific cardiac tests. Ask about an EKG, a troponin blood test, or maybe even a coronary angiogram if appropriate. This is your right. More importantly, insist that your concerns and the doctor's response or refusal, if it happens, be documented in your medical record. This is a powerful step in advocating for yourself and creates a record.
Documentation is key for accountability and continuity of care.
Absolutely. Fourth, seek support and information. You don't have to go through this alone. Look for resources like Women Heart. Their website is womenheart.org. They offer invaluable educational materials specifically for women and peer support from other women living with heart disease. Connecting with others can be incredibly empowering. And fifth, leverage wearable technology. If you're comfortable with it, consider using wearable devices like smartwatches to track your heart rhythm or blood pressure. This data, if consistent and concerning, can be a valuable starting point for discussions with your healthcare provider. It provides objective information to support your subjective symptoms. It's like bringing your own trail map to the doctor's office. Okay, those are great tips for patients. Now, what about the folks in the medical community? Sounds like they're grappling with some biases and knowledge gaps of their own. Like trying to mend a fence with the wrong tools. They need some better equipment and updated training, don't they?
You're right, they absolutely do. On the provider level, we absolutely see significant issues, and it's often not intentional malice, but more a result of systemic oversight and, frankly, outdated training. There's the persistent problem of limited time during appointments, which we all experience. There can be a lack of focused attention on women's unique presentations and often insufficient up-to-date knowledge about how CVD uniquely presents in women.
And the bias factor again.
Yes, compounding this is implicit bias, where symptoms might be too readily attributed to non-cardiac causes like anxiety, simply based on a person's sex, gender, age, race, ethnicity, or even their appearance. We've heard the personal stories women told, it's all in your head, or it's just anxiety when they were having a heart attack. This highlights a critical and deeply problematic issue within the diagnostic process.
So how do we get our medical professionals better equipped? How do we update their maps and tools and recalibrate their compasses?
Well, there are several interventions we can focus on. First, dedicated training. It's vital to provide focused education and training specifically for obstetricians, gynecologists, OBGYNs, about CVD in women. First, dedicated training. They often have frequent and long-term contact with female patients throughout their lifespan, making them a crucial frontline for early risk assessment and recognition, especially connecting pregnancy complications to later risk.
Training the OBGYNs more on heart health makes a lot of sense.
It does. Second, simulation training. We need to increase the representation of female patients and female-specific conditions in clinical and procedural medical simulation education. This can significantly improve diagnostic accuracy for conditions like SCAD, or stress-induced cardiomyopathy, where unique presentations are common in women. Practicing these scenarios builds crucial recognition skills.
Practice makes perfect, even for doctors.
Exactly. And third, perhaps most fundamentally, destigmatize symptoms. A crucial first step for all providers is to destigmatize symptoms like shortness of breath, chest discomfort, or extreme fatigue when presented by women. We need to actively stop dismissing them as simply anxiety or all in your head. Every symptom a woman presents must be evaluated thoroughly and without preconceived notions, taking every complaint seriously until proven otherwise.
Treat the symptoms seriously first. Rule out the worst possibilities. Okay, that covers patients and providers. What about the bigger healthcare system? Beyond the individual doctor's office, what needs to change system-wide to truly make a difference? It's not just about one cowboy knowing his way. It's about making sure the whole ranch is running smoothly and fairly for everyone.
You've hit the nail on the head. When we connect this to the bigger picture, this is where system-level interventions and broader policy changes become vital. The barriers here are significant. Things like limited public health outreach, specifically tailored to women's CVD risk and symptoms. Medical training that, to this day, often insufficiently addresses sex and gender differences in heart disease. A persistent lack of dedicated funding for CVD research in women, which limits the development of specific, evidence-based guideline recommendations just for them.
So the guidelines themselves might be lacking for women.
Sometimes, yes, due to lack of specific data. Add to that long wait times for specialists and geographic disparities in access to care. These are significant hurdles that disproportionately affect women, especially those in rural or underserved communities.
Okay, so how do we fix the system? What are the big picture solutions?
This is about setting up the whole ranch for success, not just one corral. It requires a strategic, wide-ranging approach. First, gender-sensitive cardiac care. We need to encourage hospitals and health systems to provide explicitly gender-sensitive cardiac care. First, gender-sensitive cardiac care. This can be fostered by joining alliances like Women Heart's National Hospital Alliance, which promotes collaboration across different medical disciplines, getting OBGYN, rheumatology, cardiology, primary care, all talking to each other to address female-specific risk factors holistically.
Breaking down the silos between specialties?
Precisely. Second, telehealth services expansion. Initiating or expanding telehealth cardiovascular consultation services is crucial. It helps bridge gaps in specialty access, particularly in rural or underserved areas where women may struggle to see a cardiologist in person. Virtual visits can break down geographical barriers. Third, dedicated diagnostic pathways. Hospitals and emergency departments should evaluate and implement dedicated CVD diagnostic pathways specifically for women presenting with potential cardiac symptoms. Third, dedicated diagnostic pathways. This ensures they receive timely and accurate diagnoses, using protocols designed for their unique presentations, rather than being subjected to male-centric protocols that might miss things. This might mean different triage questions or specific initial tests for women.
Standardizing better care for women in the ER. Good.
Fourth, address social determinants of health. It's vital to recognize and consider the profound impact of social determinants of health. Those non-medical factors like financial barriers, housing instability, discrimination, food insecurity throughout the diagnostic and treatment process. This calls for policy-level changes, strong community coalitions, and culturally sensitive support networks to support women beyond the clinic walls. Health doesn't happen in a vacuum.
Looking at the whole person, their whole life situation.
Yeah, exactly. Fifth, increase research funding and representation. We must advocate strongly for more funding and a greater focus on women's heart health research. Crucially, we need to actively work to increase women's representation, including women of diverse ages, races, and ethnicities in clinical cardiovascular trials. We need robust evidence to build treatments specific to them. We can't expect to treat what we haven't adequately studied.
More research on women for women. Makes sense.
Sixth, screening for psychosocial stress. Given the undeniable link we've discussed, integrating screening and management strategies for psychosocial stress into routine cardiovascular care for women is essential. We must acknowledge its significant impact and proactively address it, perhaps through validated screening questionnaires and referrals to mental health professionals or stress management programs integrated with cardiac care.
Connecting mental and physical health care.
Yes. And finally, seventh, leverage emerging biomarkers. Supporting research into and the eventual clinical utilization of new biomarkers, like that anti-Müllerian hormone, AMH, we mentioned for predicting menopause timing. This can help inform earlier, more personalized CVD risk assessment, allowing for proactive intervention before problems escalate. It's about using science to get ahead of the curve. Outro.
Well, we've covered a whole lot of ground today, haven't we, partner? From the hidden truths about women's hearts to the tangible steps we can all take to ensure no woman is misdiagnosed. It's been a long ride, but an incredibly important one, and I reckon we've mapped out some crucial territory here.
You're right, we've navigated some complex terrain. When we connect this to the bigger picture, the core message is crystal clear. Heart disease is absolutely a woman's disease, too. And understanding its unique presentation, distinct risk factors, and the systemic challenges in diagnosis is not just important, it's absolutely life-saving. We've talked about the subtle, often misleading symptoms, the critical role of menopause and hormones, and the heavy, often unseen burden of psychosocial stress. These aren't isolated issues, but interconnected threads.
Right, so what does this all mean for you as you ride off into the sunset today? Here are some key takeaways to chew on and act on so you can be prepared and empowered. Remember these 5 points. 1, stay alert. Know the diverse signs of a heart attack in women. It's more than just chest pain. Remember arms, back, neck, jaw, stomach pain, shortness of breath, unusual fatigue, nausea, anxiety. If it feels off, pay attention. 2, speak up and advocate. Be your own best advocate. Don't let your symptoms be dismissed. Trust your gut and ask directly for cardiac tests if you're concerned. Your voice matters.
It truly does. Don't be afraid to insist.
3, mind your milestones. Understand how pivotal life stages like menopause and pregnancy impact your heart health. Discuss these openly and proactively with your healthcare provider. They are critical windows of risk. 4, heal your head, help your heart. Recognize the powerful link between psychosocial stress and heart health. Actively seek healthy ways to manage it, whether through individual strategies or community support. Taking care of your mind is taking care of your heart. And 5, spread the word. Share what you've learned today with other women in your life, your mothers, sisters, daughters, friends. Awareness is the first crucial step towards change for everyone.
That last point is so important. Awareness can spark action. And the journey to better heart health for women requires a collective, multi-pronged effort. It extends from individuals knowing their bodies and confidently advocating for themselves, to healthcare providers recognizing biases and enhancing their training, all the way to policymakers championing equitable research and care. Every conversation, every question asked, every proactive step taken moves us closer to a future where every woman receives the timely, accurate heart care she profoundly deserves. It's a challenge we must all saddle up for together.
Couldn't have said it better myself. That's all for this deep dive, folks. Thank you for joining us on Reading Cowboys Deep Dives Heart Health series. We truly appreciate you riding along with us. Join us next time, where we'll saddle up and explore even more fascinating insights into keeping your ticker strong and healthy. Until then, keep those hearts healthy and happy, and take care of yourselves and each other out there.